Hi, and welcome to this talk on psychiatry and the legal system. My name is John Wurzel. I'm one of the faculty psychiatrists at Sacred Heart Medical Center with the Psychiatry Residency Spokane, and I'm glad you chose to join me today. We're going to cover a few different topics, and we've got a few objectives, and so we want to start by going over those. And the first is to discuss and ultimately to understand the difference between competence and decisional capacity and how they're relevant to clinical care. We're going to go from there to reviewing the components of a decisional capacity evaluation and how to do one. And then we'll transition to talking about the criteria for involuntary psychiatric holds in Washington and touch a little bit on criteria in other states, as well as the process for initiating one here in Washington. And then we're going to briefly review the many places where psychiatry and the criminal legal system intersect. Everything before that will be civil law. So when we start to think about competence, capacity, involuntary treatment, we're generally talking about a non-adherent patient, right? And so we want to think about this in an algorithmic way. So you have a patient who needs some kind of care, or a patient for whom we would recommend a certain kind of care, and they're refusing that care or not engaging in that care. So how we approach that patient, I'm going to recommend the following approach. So first, we want to address any concrete barriers to their ability to adhere. If there's something that's preventing them from being able to do what you're recommending that they do, well, they're not going to be able to succeed. And so we want to address that barrier, whether it's financial or logistical. Maybe they need a bus pass to get to the specialist that you keep recommending that they see. You've got to address that before we go down in this algorithm any further. Next, we want to make sure that the patient understands what's going on with them, what their illness is, what we're recommending and why, what are the risks and benefits of our recommendation, so that they can make an informed choice. Then we want to assess whether there's an urgent risk to their life or to their limb, essentially, to their health in a significant way. So if there is an urgent risk, and the urgent may be within the next few weeks, if there is an urgent risk of loss of life or limb, then we want to think about whether the intervention that we're recommending is a medical intervention or a psychiatric intervention or both. If we're recommending a medical intervention, then we want to assess the patient's decisional capacity and determine whether they have capacity to make the decision. If we're recommending a psychiatric intervention, then we want to determine whether the patient is a danger to themselves, a danger to others, or gravely disabled. And if they are those things, then we would think about a referral to the DCR, as we'll discuss later. And if we think they need both a medical and a psychiatric intervention in an urgent way, then we want to both do a decisional capacity assessment around the medical issue and a psychiatric evaluation around the psychiatric intervention in parallel at the same time. So what do we do if we suspect that the patient needs a medical intervention in an urgent way and lacks the capacity to make that choice? Well, we need to evaluate them. And the first thing I want to discuss is the difference between competence and decisional capacity. So the two terms are often used interchangeably, and that is unfortunately inaccurate, right? So competence is a determination that is made by a court. So unless you have a JD degree or you're sitting on a jury, you're never going to be determining someone's competence. It's not a decision that physicians have the right to make. Competence is a legal term, and there's lots of different kinds of competence, and they all refer to whether someone has the ability to participate in various stages of essentially civil life in the legal process to make decisions for themselves, right? And so there are competencies to obviously make medical decisions, to manage one's estate, to vote, to stand trial, to be executed. And so there's lots of different competencies, and they're all determined by a court. So the most common competence that we see are those involving guardianship of person. So patients who are deemed incompetent of person are assigned a medical guardian to make decisions for them. But like I said, there's also competence to stand trial or to plead guilty, to waive counsel, to be executed, to vote. Lots of different competencies all surrounding participation in the legal system. Competence is generally determined for a specific length of time. It's usually reevaluated every 6 or 12 months by a judge or a jury. And so by contrast, decisional capacity is determined at a single moment for a single medical decision, right? So a patient can lack the capacity to make a decision one day and regain the capacity to make that decision the next day. For example, their delirium clears up and they've regained the capacity to think clearly and make that decision. A patient can also lack the capacity to make one medical decision and simultaneously have the capacity to make another medical decision. We'll talk about examples, but so we can see how that's very different than competence, which is generally overarching across all medical decisions if you lack the competence to make medical decisions, and is generally for a fixed duration, after which it'll be reevaluated. And unlike determining whether someone is or is not competent, determining whether someone does or does not have decisional capacity to make a specific medical decision is absolutely in the purview of a physician, and all different kinds of physicians, including psychiatrists, but also any other physicians. So I recommend looking at Dr. Applebaum's paper, The Assessment of Patients' Competence to Consent to Treatment. The first thing I would point out is that he misuses the word competence in the title of his paper, and while he makes a very reasonable argument that the two terms should be used interchangeably, the legal system actually determines the definition of the two terms, and so they cannot be used interchangeably. Beyond that, though, I think Dr. Applebaum is spot on for a lot of what he discusses in this paper. So turning our attention more specifically to decisional capacity evaluations, which we will hopefully be doing lots of during the course of our career. Decisional capacity refers to the ability of the patient to make decisions about their own medical care. It essentially asks whether they can provide informed consent to make a specific medical decision. It can be evaluated by any physician who feels comfortable doing so. Like I said, you don't need to be a psychiatrist to do it, although we're always happy to help. So it's worth knowing also that a patient who the courts have determined to be incompetent around medical decisions cannot legally have capacity to make those decisions. If the court has said you can't make medical decisions right now, then your capacity status doesn't really come into play. It's also important, though, to remember that there's lots of different kinds of competence, and so there's lots of different kinds of guardians. So someone may be incompetent to manage their finances and have a guardian of estate appointed. They may be incompetent to make medical decisions and have a guardian of person appointed. There are people who are determined to be incompetent to work with their lawyers in a divorce trial, and they'll have a guardian appointed specifically to work with the lawyers on their behalf. And so just because someone has been deemed incompetent or just because someone has a guardian appointed does not mean that they've been deemed incompetent to make medical decisions or that that guardian is a guardian of person. So it always is important, if you see that someone's been appointed a guardian, to determine what kind of guardian that is, and whether they have guardianship of person authority. Otherwise, if the patient has a guardian of estate and you call that guardian of estate to help you make medical decisions, you've not only called someone who's really unqualified to do that, but you've also violated the patient's HIPAA protections. Finally, children all automatically have guardianship of person implied. So their parents are generally their guardians unless someone else has been appointed by the state. And there are some exemptions around, reproductive health and mental health issues in the state of Washington at various ages in your early teens. But other than that, all children have guardianship of person implied and assumed. So to review the logistics of decisional capacity, so capacity determinations can be made by any physician for any specific medical decision. A patient's capacity to make a decision can change from day to day, and it can, at any given time, vary from decision to decision. Again, someone can have capacity to make one decision while simultaneously lacking capacity to make another decision. Capacity determines whether a patient can provide informed consent to make a medical decision, and patients who have guardians of person cannot legally be capacitant. All right, so let's talk about how you would determine whether a patient has decisional capacity on the ground. And we would do this by answering 4 questions, or by having the patient answer 4 questions, right? So the first question is whether the patient can understand the information that's relevant to their situation. And that is essentially asking whether the patient understands the medical condition for which we're proposing treatment and what the proposed treatment and alternatives are. The level to which they need to express that understanding probably varies by situation, but to me, I'm usually looking for them to be able to accurately identify the organ or the organ system that's involved and the direction of dysfunction, right? So if somebody has an acute exacerbation of their congestive heart failure and they're able to tell me that their heart's not working as well as it should, generally in my book, that would qualify as adequate understanding of the medical condition that we're dealing with. If we're proposing a complicated chemotherapy regimen and the patient is able to tell us that we're proposing these medications to treat their cancer and the side effects that we're mostly worried about are A, B, and C, that again is probably an adequate understanding of the proposed treatment. Right? Often we see the decisional capacity evaluation really ends with this question. So many of the patients that we're doing capacity evaluations are unable to tell us what the medical condition is, why they're in the hospital, what the proposed treatment is, and if they cannot answer those questions, then they cannot demonstrate decisional capacity. It's worth knowing that the expectation is not that they be able to spontaneously volunteer this information, right? So if we go back to our algorithm on how to address non-adherent patients, the second step of the algorithm is to make sure the patient understands the situation. We need to give them adequate education, and that's why it's saying, can the patient parrot this information back? So before you're determining whether someone understands their medical condition, the proposed treatments, you need to make sure that someone has explained to them their medical condition and the proposed treatments. The second question is whether the patient can appreciate their situation and its likely consequences. And this is essentially asking whether the patient can understand the risks and benefits of the proposed treatment and the proposed alternatives, including no treatment, if that's what they're trying to elect for, right? So again, we want to be mindful that we've explained this to the patient before we ask them to explain it back to us. Again, we want to have a reasonable threshold for not requiring medical jargon in interpreting their answer. And again, the patient needs to be able to clearly demonstrate this to us in order to meet the threshold of having decisional capacity. The third question is whether the patient can rationally manipulate the information. And this is essentially a question about whether the logic behind the patient's decision-making is internally consistent with their past logic, with their life experiences, their understanding, etc. So this is the most subjective element of the decisional capacity evaluation from our perspective, our ability to determine whether the patient is making a rational decision is subjective, right? And really, there isn't a magic way to do this. So the primary tool that you're going to use to determine whether the patient is being rational is just the diagnostic interview itself. There's no specific question that you can ask outside of just why are you making the decision that you're making, and then assessing it. So I'll give an example because that might be helpful. We had a patient who was found down in florid septic shock, brought into the hospital, discovered to have infective endocarditis, and he had septic emboli to his lungs. And he tolerated being in the hospital for about a week. They were recommending 6 weeks of IV antibiotics, but after about a week, he decided that he really couldn't tolerate being here anymore, and so he asked to leave. We did serial assessments of his capacity over a few days, during which he sort of developed the capacity to understand the situation, understand the treatments and alternatives. And so on the last day of his being in the hospital, we asked him, what's wrong? And he was able to say, hi, I have an infection in my heart, and there's little infections in my lungs, and the doctors are telling me that if I leave, I might die, and that I need to take these antibiotics, which could save my life, but I still want to leave. And we said, well, walk us through your reasoning. And he said, if God wants me to live, then he'll keep me alive, and if God doesn't, then I'll die, and it's really in his hands. And happily, one of his friends was there and was able to say that, yeah, this is how, we'll call him Fred, this is how Fred has always made decisions. He just sort of puts things in God's hands. His wanting to leave is completely consistent with his life history. He often acts like this. Fred then said, for example, I had this really bad abscess on my arm a few years ago that the doctors were saying if I didn't get antibiotics to treat it, then it could get worse. And again, I put it in God's hands, and it went away on its own without any medications. And so I think that that's what might happen here. Now, it made us all very uncomfortable, but we were able to look at the situation, especially with the collateral from his friend, and say that, yeah, Fred's making decisions that are internally consistent. He has past experience which supports his decision-making sort of pathway, and this is consistent with the way in which he usually makes decisions, and so it does appear that he actually is rationally manipulating the information. And so we ultimately decided that he had capacity to leave against medical advice. Thankfully, his friend talked him into coming into the infusion clinic and getting IV antibiotics weekly, which made us all feel a whole lot better. But even if his friend hadn't done that, we had determined that, yeah, he really does have capacity to leave. It's important to note that we cannot ask the patient to demonstrate logic in the same way that we would demonstrate logic, because otherwise we would be asking them to reach the same conclusion that we would be reaching. And so the question is it internally logical, given their life experiences and the way they make decisions? Finally, we want to ask whether the patient is communicating a consistent decision. And this is actually kind of a two-part question. The first part is the patient communicating a decision? If the patient's unable to communicate, they're unable to demonstrate capacity. It doesn't have to be verbal communication necessarily, but it does have to be some form of communication that allows them to express an adequate level of detail to demonstrate all of the things that we've discussed so far. And the second part of the question is that communication consistent? And so there we would be asking whether they're, waxing and waning. If they're changing their mind all the time, that suggests that they really don't have capacity to make a decision. So in order to have decisional capacity, the answer to all of the four questions we've discussed has to be yes. They have to demonstrate that they understand the situation, that they appreciate the situation, that they are rationally manipulating the information, and they have to be communicating a consistent decision. It's not like if you get 3 out of 4, you get credit. No, you have to have yes, 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 yes. So how do we operationalize these questions in the interview with the patient? How do we actually ask the questions that we've just discussed? So here's generally how I ask them. So I might start by saying, can you tell me what medical issue you're being treated for, or what brought you into the hospital, or what medical condition do you understand that you have, in order to elucidate their understanding of their situation. And then I tend to follow up with, what are the doctors recommending in terms of treatment? And what would the risks of that be? Well, what treatment would you prefer? And what would the risks of that be? To get a better understanding of whether they're really appreciating the situation. And then in order to assess whether they're rationally thinking things through, I want to know, why are you making the choice that you're making? Or please explain your reasoning behind that choice. I'm not going to have to ask about consistent communication. I'm just going to be assessing that during the course of the interview. There's one other factor that I always think about. So there's 4 questions and like one bonus factor. And this bonus factor is that the stringency of a decisional capacity evaluation depends on the relative risks and benefits of the situation. So the more risk that the patient is assuming, the more clearly they need to demonstrate capacity. We'll go through a couple examples in order to make this more clear. So a patient who wants to refuse a very safe, life-saving treatment like antibiotics in the setting of an infection, right? Like that patient, because they're assuming a lot of risk, has to very clearly demonstrate that they have decisional capacity in order to refuse that intervention and assume that risk. By contrast, a patient who is accepting antibiotics in the setting of an infection, we generally don't even assess their capacity because the threshold, the degree to which they need to demonstrate capacity is so low that just accepting it is almost good enough. It's probably technically not good enough, but it's almost good enough, and we probably just round up. So a patient needs to only nominally demonstrate capacity to consent to a very safe, life-saving treatment. By contrast, a patient who wants to consent to a highly risky treatment, like an experimental surgical intervention or a new chemotherapy drug or something, that has a lot of risks associated with it, they need to very clearly demonstrate their capacity to agree to that treatment, while a patient who wants to refuse a highly risky treatment is going to be held to a less stringent standard. So the standard to which the patient needs to demonstrate capacity is going to vary with the amount of risk that they are assuming. As we think about decisional capacity, I keep saying the patient has to demonstrate decisional capacity. And I want to touch on that briefly, because if we think about decisional capacity in the context of the legal system, it's a really unusual situation. Our legal system, and that of most Western countries, is based on the principle that people are considered innocent until proven guilty. So the burden of proof lies on the prosecution. Unfortunately, in terms of capacity evaluations, the opposite is true. As soon as someone questions your capacity, you are presumed incapacitant until you prove yourself capacitant, until you demonstrate capacity. If that feels ethically uncomfortable, it probably should. But unfortunately, there's really no other way to go about it. It's impossible for us to say that if we are concerned about someone's lack of capacity and they refuse to say anything, that alleviates our concern, right? So the burden really does fall on the patient to demonstrate that they have capacity by demonstrating that they can answer those 4 questions to an appropriate level as determined by the amount of risk that they're assuming. What do we do if the patient doesn't have decisional capacity? Well, the first thing to know is that does not automatically mean that they should get the intervention against their will. If at all possible, you want to get a surrogate decision maker, durable power of attorney, or a next of kin based on Washington state surrogate hierarchy, in order to help make that decision on behalf of the patient. If no surrogate decision maker can be found in a reasonable amount of time, then the decision of whether to proceed is based on the physician's judgment. And we need to review 2 concepts here. The first is the idea of best interests. So we treat to best interests in a few situations. Children's treatment is always targeted at a best interest standard, which means that the decision about what to do in terms of treatment should be made in order to do whatever is best, medically speaking, for the patient, for the child in this case. Regardless of what the parent says, children's treatment proceeds on a best interest standard, which is why, for example, Jehovah's Witnesses cannot refuse blood products for their children. Similarly, in an adult, if we have no other information about what the patient might want, then we proceed on a best interest standard. So if we have a John Doe or a Jane Doe come into the emergency room, they're obtunded, there's no surrogate available, we don't know who they are, it's very hard for us to find a surrogate, they need an urgent or emergent intervention, and they're unable to speak because they're obtunded, then we're going to proceed on a best interest standard. We're going to do whatever is in the best interest of the patient. Although it varies from state to state, similar protections exist around Good Samaritan interventions. So if you, for example, are driving down the street and there's a car accident and the person in the accident is injured to the point that they can't speak, then you are, as a physician, obligated to render whatever care you can to a best interest standard. You do what you believe is in the best interest of the patient. The opposite of that, or the alternative to that, is a substituted judgment standard. And a substituted judgment standard is actually far more common in medicine. The substituted judgment standard asks, what would the patient choose to do if the patient were able to make the choice for themselves? And that is what, most of the time, a patient who lacks decisional capacity, that's what their surrogate should be using as a standard to make decisions on their behalf. So if we have a patient who lacks decisional capacity and we reach out to the surrogate, one of the most important things we can do is tell them that it's actually not your job to make a decision that's in the best interest of the patient. It is your job to represent the wishes of the patient. And the reason that you are a surrogate is because you're someone who knows those wishes well. And that's why the surrogacy hierarchy is what it is, and it's why it starts with immediate family. It's all designed around who would be best able to represent the patient's wishes, which may or may not actually align with what would be in the best interests of the patient. There are situations where the patient's wishes are relatively clear, but they lack capacity. For example, they're intermittently delirious. When they're less delirious, they're able to tell you what they want, but unfortunately, because of their delirium, they're unable to communicate a consistent choice. And so the way that we incorporate their wishes is by saying, well, they still lack capacity, we still need a surrogate decision maker to make decisions on their behalf, but that surrogate decision maker needs to take into account what the patient is expressing as their desire when they're more apparently clear, and reconcile that with things they've expressed for the previous parts of their life, etc., etc. So the majority of cases in adult medicine, surrogate decision makers are instructed to make decisions on a substituted judgment standard. And that includes us. So if we have a John or Jane Doe who comes into the emergency department, we can't find a surrogate to make decisions for them. They appear to lack capacity, but again, they appear to be having lucid moments in which they're expressing a clear choice. Then they still lack capacity if they lack capacity, but we can make a decision based on substituted judgment using the statements that they're making in their lucid moments to try to inform our decision as best we can. So let's look at a few cases to better understand this idea of capacity. In the first one, we've got a 63-year-old man with a history of alcoholism and end-stage liver disease who's admitted for bleeding esophageal varices. Once he's acutely stabilized, the GI service strongly recommends that he get an EGD for banding the vessels, stating he'll likely die within the month if not. The patient refuses the procedure, stating no one's putting anything down his throat. So what questions will you ask him to evaluate his capacity? So stop the presentation, pause, write down the questions you would ask this gentleman. All right, so those would be, can you tell me why you're here in the hospital? What medical conditions are they treating you for? What medical conditions brought you in? And what interventions are being recommended for the treatment of those conditions? And what would you prefer to do? All right, what are the risks associated with the treatments? And what about the benefits? And what are the risks of not getting this treatment? and the benefits of not getting this treatment. So you ask those questions, and the patient responds that he's in the hospital because he's a drunk, and states that he was puking blood. And he tells you he's been in the hospital dozens of times, and that they keep telling him there's something wrong in his throat. He confidently states that the docs are full of bullshit, though, and that there's nothing wrong, and that they just want to make more money by doing unnecessary shit. Your efforts to educate him otherwise are unsuccessful. You ask what the recommended treatment is, and he says, well, they want to put some hose down my throat. When you ask what will happen if he doesn't get the recommended treatment, he replies, nothing, because I don't need the treatment anyway. So does this patient have decisional capacity? Let's walk through question by question. The first question, does he understand the information relevant to his situation? Pause and write down what you think and why. So I would say no. He understands that he's got an alcohol use disorder, but he doesn't understand that there's anything wrong with his throat. He might understand the recommended intervention by saying that they want to put a hose down his throat. It's not clear to me whether that is a good enough understanding or not, but he clearly does not understand what's wrong with him. And so you could stop here. He has failed to demonstrate capacity. But you do want to document a full capacity evaluation. So then we're going to ask, does he appreciate the situation and its likely consequences? Again, pause and write down what you think the answer is. So no, he denies that anything bad will happen. He says there's nothing wrong with him, and so nothing's going to happen if I don't get this procedure. Can he rationally manipulate the information? To me, it seems like, yeah, his conclusions logically follow his flawed understanding of the situation. He thinks there's nothing wrong with him, and that therefore, if nothing is done, nothing bad will happen. That's logical. And is he communicating his decision consistently? So I would say, yeah, he seems to be saying he doesn't want this done. It seems like he's doing that consistently. So finally, we would ask, what are the objective risks and benefits of the treatment he's refusing? And based on those, to what standard should we hold this patient, right? And I would say that, the recommended procedure is relatively low risk with potentially life-saving benefit. And so because of that, he must clearly demonstrate the capacity to refuse this intervention. Now, I do want to add one thing, which is that this kind of case brings up the question of, if the patient lacks capacity, and if the surrogate decision maker says, acting on the patient's substituted judgment, that they believe the intervention should be performed, you do want to make sure that the primary team, whoever it would be, in this case GI, is comfortable performing the intervention. Right? So if GI is saying, we really feel uncomfortable strapping this guy down or anesthetizing him as required in order to do an EGD when he's clearly telling us over and over again that he doesn't want one, regardless of whether he has or lacks capacity, then I think there's a couple things to consider. The first would be an ethics consult, right? Because the whole idea is not that lacking capacity gives us the right to violate someone's wishes. The idea is that lacking capacity indicates that someone is not currently able to express what their real wishes are, which is why we ask a surrogate to act on their behalf in doing so. And so, involving ethics, if the primary team is really uncomfortable doing an intervention that the patient's refusing, despite them lacking capacity and having a surrogate decision maker who says that that is what they would want under normal circumstances, is a very appropriate thing to do. The other thing I often do is say, I don't know if you really, if you already know you're not going to intervene if this patient lacks capacity, I don't know if you really want me to do a capacity evaluation on this patient, because then I'm going to document that the patient lacks capacity, that you should seek a surrogate to make decisions on their behalf, and it can just put other providers in an uncomfortable situation where, should something go wrong, they're in a position where they have to explain why, despite the clearly documented lack of capacity and the suggestion of finding a surrogate decision maker, they elected not to do anything. and that can be a little uncomfortable for them. All right, let's look at another case. So now we have a 45-year-old woman with a history of metastatic breast cancer who's admitted for acute on chronic renal failure secondary to a combination of metastatic lesions and chemotherapy medications. There's a multidisciplinary conference with her and her family shortly after she goes on dialysis. The oncology and renal teams are there. The oncology team would like her to participate in a trial involving a new chemotherapy drug currently in stage 2 clinical trials. The renal team would like for her to continue dialysis and to take a cocktail of antihypertensive drugs to manage her systolic blood pressures, which have been running around 185. The patient refuses all of these interventions, saying that she's just done with everything. So again, pause and write down what questions you'll ask her in order to evaluate her capacity. So again, same questions. Can you tell me why you're in the hospital? What medical conditions are you being treated for right now? What are the treatments that are being recommended? What interventions are being recommended for your condition or your conditions? And what would be the risks associated with those treatments? And what about the benefits? And you're telling us that you're just done with everything, so what would be the risks associated with being done with everything? And how about the benefits of that? So you ask these questions to the patient, and she seems a little confused. She's intermittently drifting off during the interview. She tells you that she has cancer and that her kidneys are shot, and when you suggest there might also be a problem with her blood pressure medication, she says, sure. However, she quite clearly states that medications have only made her feel worse, and tells you about the vomiting and the exhaustion from chemotherapy, and then angrily declares that the chemo is also what destroyed her kidneys. You ask her about what the risks and benefits of the new chemotherapy drug are, and she says, who knows, it'll probably destroy my lungs next. Before you can clarify further, she seems to drift off to sleep again. You wake her up and explain the new medication to her again, but she can't seem to hold on to what you've told her. When you ask her about antihypertensive medications, she says, well, that's what they want me to take, but then returns to complaining about the chemotherapy, seeming to be unaware that you and she have already discussed it. When you ask about dialysis, she only says no more needles and then drifts off again and refuses to talk anymore, saying that she's too tired. So, we want to think about a few learning points here. The first is about whether she has decisional capacity. So, stop and write down the answer to this question. Does this patient have decisional capacity? Why and why not? All right, so it's a trick question, right? And the real question should be, does this patient have decisional capacity to refuse chemotherapy first? And I would argue probably not, but let's walk through it. So does she understand the information relevant to chemotherapy decision making? So I'd say, yeah, she knows she has cancer, and she's aware of this drug that they're recommending. Does she appreciate the situation and its likely consequences, right? So no, you tried multiple times to explain about the potential side effects associated with the chemotherapy drug, and she doesn't seem to be able to retain those. So she doesn't appreciate the situation. Is she rationally manipulating the information? It's hard to know, really. And is she communicating her decision consistently? Yes. So then we would look at, well, what are the objective risks and benefits of the treatment, this novel chemotherapy? And based on that, what standard should we hold this patient to? So we know that this is a new chemotherapy drug in stage 2 clinical trials. Based on that, we know that there's really little evidence regarding whether the procedure would work. It's still in stage 2 trials. And there's fairly little evidence about whether what the risk profile would look like. We can extrapolate from similar treatments, late-stage cancer interventions, which tend to be relatively low benefit and relatively high risk or high side effect burden. And based on all this, I would say that the standard for her to refuse is very low. In fact, the Institutional Review Board associated with this clinical trial would have to be pretty convinced of her capacity in order to allow her to enroll. So her refusing is a fairly low threshold. So that's question number one. Does she have capacity to refuse chemotherapy? Question number two would be, does she have capacity to refuse dialysis? And again, the answer is probably no, right? So if we walk through our questions, we would say, does she understand the information relevant to this situation? And when you asked her about dialysis, she just said no more needles, but gave no other indication that she understands what dialysis is. She said her kidneys are shot, so she gets credit for that, but she can't explain anything about dialysis, and she certainly can't tell you the risks and benefits associated with accepting or refusing it, so she really does not have decisional capacity to refuse dialysis. Now again, we need to ask, what are the risks and benefits of the treatment, and what standard should we hold her to? So we know that dialysis is low risk, relatively speaking, and high benefit, probably save her life, in addition to which it may also restore her ability to think clearly and may restore her capacity, right? And so interventions that restore decisional capacity are sort of especially favored by courts, because what we really want is for patients to be making their own decisions in their right mind. And so I would say that she does not have the capacity to refuse dialysis, and that a surrogate should be sought to make that decision on her behalf. Then finally we would ask, well, does this patient have decisional capacity to refuse antihypertensive medication? And I would conclude no, but we might wait to treat, because again, does she understand the information relevant to the situation? Yeah, she sort of nominally agreed that she has a blood pressure problem and agrees that antihypertensives are what the doctors are recommending. But she can't appreciate the risks and benefits associated with the treatment or with refusing the treatment, and so she doesn't have the capacity to refuse antihypertensive medications. That said, when we look at the objective risks and benefits, although antihypertensives are low risk and high benefit, the risk is not so acute that it might not be reasonable to wait to see if dialysis restores her capacity, or to see if dialysis addresses her blood pressure issues adequately until her capacity can be restored, and then we could reassess her capacity around antihypertensives. And so I think that this is a great case because it illustrates a number of points. The first is that there is no such thing as global capacity. Right, so you cannot ask, does she have decisional capacity? You can only ask, does she have decisional capacity to make a specific choice at a specific time point? And that's why we had to ask 3 separate questions. The second thing I would point out is that you really want to be thoughtful about your interview with this kind of patient, because she clearly was more engaged at the beginning of the interview when you were talking about the chemotherapy regimen than at the end of the interview when she was nodding off and really unable to talk about dialysis. But from a clinical perspective, dialysis is probably the more important thing to acutely discuss. And so I would say, you want to reorganize this interview. I would start with the dialysis and probably do the cancer discussion last. Moreover, the difference in a few days in terms of the cancer chemotherapy regimen is unlikely to be major, and so it may well be reasonable to address the question of dialysis, restore her capacity if possible, and then have the conversation about the chemotherapy. And the last point that I would make is that if you recognize that this patient is likely delirious based on the case presentation, you're right. And that doesn't necessarily mean anything about whether the patient has capacity or not. There is no diagnosis that answers the question of whether a patient has capacity. Patients who are delirious can have capacity. Patients who have no diagnoses can lack capacity. And anywhere in between, patients who are demented can have capacity. The only automatic thing about capacity is that if someone has been deemed by the court to be incompetent to make medical decisions, then we know that legally they cannot have capacity. But other than that, regardless of diagnosis or clinical situation, any patient can or cannot have capacity, and so you have to do an assessment to make that determination. One more bonus case, and this is a case from my clinical experience. So I was on call at the VA hospital and got called at 3 a.m. by the surgical team asking me to see a guy in his low to mid 60s who had a really sad story. He'd been misdiagnosed with hepatocellular carcinoma, and they did surgery to remove what turned out to be a benign hepatic lesion. But while undergoing surgery, he had a paralyzing spinal stroke. He stabilized from that and discharged, and then was readmitted for the hospitalization during which I was consulted for essentially placement issues. He was waiting to get placed in an adult family home or assisted living. For some reason I don't remember, they did a routine x-ray the afternoon the afternoon before the night that I was consulted, and happened to find free air under the diaphragm. This was a totally surprising finding. No one had any idea why this guy would have a pneumoperitoneum, but he did. And a pneumoperitoneum, as you may know, implies bowel rupture, and really emergency surgery is the only treatment that'll prevent death in most cases. But the patient refused. So the surgery team saw this x-ray, went to see him, and he told them that he had faith in Jesus and that he understood that he might die without surgery and that he was tired of being paralyzed. The surgical team called the anesthesiology team, who had largely the same conversation with him. And then when they were done talking to him, the surgery team called me. And so I drove in at 3 in the morning and went and saw the patient. And by the time I saw him, he was really quite delirious. He was talking over and over again about Jesus, increasingly upset about doctors keeping bothering him, upset enough and delirious enough that he just kept asking me to leave and saying he had faith in Jesus. I asked him what was wrong with him, couldn't tell me anything specific or even the organ system involved, just that he was really sick. When I asked if he understood he might die, he would only respond repeatedly by saying he had faith in Jesus. And so I called his only living relative, who was a brother, and his brother told me they hadn't spoken in 10 years. He had no idea what the patient might want or what was going on with him. So put yourself in my shoes. You've got the surgical team, it's 3 in the morning. By now it's probably 4:30 in the morning. This guy is clinically decompensating, and they want to know, does he have decisional capacity? So why don't you pause and write down what you would have done in this situation. All right, so the first thing is that no, he does not have decisional capacity, right? Saying that he's really sick is just not a good enough demonstration of an understanding of the situation. He clearly can't tell me about the risks and benefits. Saying that he has faith in Jesus is just not adequate. And so he does not have decisional capacity. Moreover, it's a high benefit, life-saving, relatively low risk surgery. And so the threshold for him to demonstrate capacity in order to refuse this would be quite high. He does not reach that threshold. That said, based on what the surgery and anesthesia teams told me, it sounds to me like he did have capacity when they talked to him, right? And so this is a situation where he doesn't have decisional capacity, and so we need to look at a surrogate decision maker. The only surrogate decision maker in the Washington state hierarchy essentially said, his brother essentially said that he couldn't make any decisions, and so it fell to the medical team to act as his surrogate decision maker. And the surgical team was really uncomfortable performing surgery against his will, understandably. And so we looked at it and we said, well, acting as his surrogate, he has consistently expressed this wish not to have surgery. He appeared to have capacity when he was initially expressing his wish not to have surgery. And so it's currently our job to represent his wishes as best we can, assuming those wishes were when he was capacitant, which it seemed like they were. And so we chose to respect his stated wishes, and the patient died the following day. It's a really tough case, but I think a good illustration of how, even when a patient doesn't have capacity, using substituted judgment, which is the ethical and legally appropriate thing to do, may still result in not treating them. All right, now we want to turn our attention and look at involuntary psychiatric treatment. So everything we've talked about so far has been involuntary medical treatment. And again, when we're looking at the non-adherent patient, after we've eliminated concrete barriers, after we have educated them about the situation, we then want to figure out whether and after we've determined that there's some urgent need for intervention, we then want to determine whether the recommended intervention is medical, psychiatric, or both. If it is medical, then we want to go through the whole process that we just talked about related to capacity. If it's psychiatric, then we want to think about involuntary psychiatric treatment. So, involuntary psychiatric treatment requires that a patient have a treatable psychiatric illness that has rendered them a danger to themselves, a danger to others, or gravely disabled. We'll talk about how in Washington State, it is ultimately the county, a representative of the county, who makes this determination, but I strongly encourage you to make this decision for yourself before you reach out to the county and ask them to help. So, a danger to self means that the patient poses an imminent risk of intentional loss of life or limb to themselves. Danger to others means that the patient poses an imminent risk of intentional or unintentional loss of life or limb to someone else. Sometimes includes property damage. And grave disability requires that the patient is at imminent unintentional risk of loss or life or limb, and generally this needs to be demonstrated by an inability to provide food, shelter, or care for a significant medical condition, to which you'll need to cite laboratory studies or medical findings demonstrating that the patient is having medical consequences of their inability to provide for themselves. So it may be low prealbumin because they are starving, it may be frostbite or hypothermia because they're unable to provide adequate shelter, it may be electrolyte abnormalities due to malnutrition in some way, it may be really uncontrolled glucose measurements due to their inability to manage their diabetes, it may be dangerous clotting findings if they're on Coumadin, etc. So you need to have some demonstrable inability to provide food, shelter, or care for a potentially fatal medical condition. So in Washington State, anyone, including a physician, who believes that a patient poses a danger to themselves or danger to others or is gravely disabled, then calls the county and asks that a designated crisis responder be sent to assess the patient. As a county representative, you reach them by calling the regional crisis line. So through First Call for Help here in Spokane. The county then sends out a representative, and while you are waiting for the representative to arrive, which can take up to 12 hours, 24 in some clinical settings, the patient is involuntarily held until that assessment. They cannot be involuntarily medicated, however, unless it is emergent, by which I mean involuntarily medicated for the treatment of their psychiatric conditions. If you're thinking about a medical need, then you should be looking at the capacity walkthrough that we've already discussed. The designated crisis responder will do their assessment and determine if the patient needs to be detained for involuntary psychiatric treatment for up to 72 hours. And that 72-hour hold automatically includes the right to involuntarily medicate the patient with antipsychotics. Does not include the right to involuntarily medicate the patient with any other psychiatric medications for a psychiatric indication. Again, if there's a medical indication, then you want to look at capacity, but for psychiatric treatment, the 72-hour hold allows for their involuntary detention to a psychiatric facility and their involuntary treatment with antipsychotic medications. after 72 hours. And then again at 14 days, at 90 days, and every 180 days, the patient has a hearing before a judge or a commissioner that'll determine if the hold should continue. For all of these durations of time, except the 180-day hold, the right to involuntarily medicate the patient with antipsychotics is automatically included if the patient is held. Patients on a 180-day hold require a separate hearing in order to determine whether they can be involuntarily medicated against their will. It's almost always the case, but if you admit a patient who's on a 180, you do need to double check that this hearing has happened and what the outcome was. In the majority of the rest of the United States, the threshold for holding a patient is a 2 or sometimes even 1 physician hold. So if 1 or 2 physicians, depending on the state, agree that a patient represents a danger to themselves, a danger to others, or is gravely disabled, the patient can be involuntarily held for psychiatric treatment. Depending on the state, that hold may or may not include the right to involuntarily medicate the patient. So, for example, when I was in California, there was a 2-physician hold to involuntarily hospitalize a treatment for a psychiatric condition, but it did not give you the right to involuntarily medicate the treatment until they'd had their 72-hour hearing before a commissioner. So you could detain a patient for 72 hours, but you couldn't necessarily treat them, which often was very frustrating because we'd be essentially babysitting this very sick person in the hospital, but we didn't have the right to treat them until they had had a hearing before a commissioner. Generally, there's a 72-hour hearing, and then there's hearings at various time points going forward. Again, it varies state to state, and so if you're practicing outside the state of Washington, you need to be familiar with the local laws. We also need to consider the Tarasoff case law and the duty to warn. So Tarasoff versus the Regents of the University of California was a case from the 1970s in UC Berkeley, where a student was seeing a counselor through UC Berkeley and disclosed that he was having thoughts of murdering another student, Miss Tarasoff. And due to confidentiality requirements, the counselor kept that confidential. And ultimately, the student did murder Miss Tarasoff, unfortunately. And her family sued the regents of the university and sued the counselor, saying that he should have warned her about this. And ultimately, the outcome of the case was the determination that health providers are legally obligated to break confidentiality in a situation where there's an imminent risk of harm to a third party. So, if your patient threatens to hurt a specific person or people, and that threat is within the realm of possibility, you are obligated to warn that person or people at the time of the patient's discharge from your care, if they're in the hospital, or when they leave the office if you are in a clinic. So the Revised Code of Washington states that the duty to warn or take reasonable precautions to provide protection from violent behavior where the patient is communicated an actual threat of physical violence against a reasonably identifiable victim or victims. That duty is discharged if reasonable efforts are made to communicate the threat to the victim or victims and to law enforcement personnel. So, if your patient is making an actual threat of physical violence against a reasonably identifiable target, you are obligated to notify that target and to notify law enforcement personnel by calling Crime Check or the non-emergent police number and letting them know about this at the time when the patient is going to be able to enact that threat, which is when they leave the hospital if they've been in the hospital, or leave the clinic if they were in a clinic visit. It's also important to know that there's case law in Washington state that actually made this standard even increase the standard even more, or increase the burden on providers even more, and that's the case was Volk. And unfortunately, the Volk case isn't fully resolved, and so we don't know exactly what the new standard is, but currently it replaces the idea of reasonably identifiable victim or victims with the idea of foreseeable victim or victims. It's very hard to know exactly how that translates or how that's going to translate, but it's worth being aware that that's happening right now. Now I want to briefly touch on where psychiatry and criminal law intersect. Because there's a lot of intersections, they can be really interesting, and they get a lot of media attention sometimes. So when we think about criminal law, so a crime is committed and an arrest is made. After the arrest, there's the possibility of a competency assessment. So we talked about how there's lots of different kinds of competencies, and one of those competencies is competency to stand trial. So the defendant may be, the defendant's competence may be called into question, and then a formal assessment will have to be done before they can go to trial. If the defendant is deemed incompetent to stand trial, then they'll go generally to a forensic unit where a psychiatrist will attempt to restore their competence. If their competence can't be restored, then they will be involuntarily hospitalized in a forensic ward until they're deemed to no longer be dangerous, essentially. If either they are deemed competent initially or their competence is restored, then that'll proceed to trial. Now, during the trial, there may be a not guilty by reason of insanity plea, and there may be expert testimony by a psychiatrist. It's worth knowing that the minority of patients actually get competence assessments. Your competence is assumed unless there's some indication that you might lack it. Now, as an outcome of trial, possibilities include you're found to be not guilty, in which case you're released. You're found to be guilty, in which case you go to jail or prison, where there is lots of psychiatric treatment, right? So the biggest psychiatric ward in the United States is the LA County Jail. You may be found not guilty by reason of insanity, in which case there will be an assessment of whether you are still dangerous, a forensic assessment of whether you're still dangerous. If you are still dangerous, then you will be involuntarily hospitalized in a forensic ward. If you're not still dangerous, you may be released. And there is a trend over the last 20 or so years toward this concept of being guilty and insane. So in that circumstance, you're sent to jail or prison with psychiatric treatment, and then at the time that you fill your sentence, you finish your sentence, there's an assessment of whether you're still dangerous, and if you still are dangerous, you may be then sent to a forensic ward for involuntary psychiatric hospitalization. If you're not dangerous, you may be released. So all the blue boxes represent points where the criminal law and the psychiatric practice have the potential to intersect. You can see there's a lot of blue boxes, and this is why it gets lots of media attention and those sorts of things. It's also worth knowing that there is an association between mental health issues and criminal behaviors. It varies by mental health issue, and it's often the opposite of what we might think. So people with schizophrenia, for example, are often portrayed as perpetrators of violence in the media. And the reality is that there is association between schizophrenia and violence. And the association is that people with schizophrenia are dramatically more likely to be the victims of violence. They're not more likely to perpetrate violence, but they are much more likely to be the victims of violence. And so I also want to point out that there are associations between psychiatric illnesses and criminal behavior, and they often are not the direction that one might assume. Just quickly by talking about the not guilty by reason of insanity plea, because it gets so much media attention. When we look for historic exemptions from full punishment, it dates as far back as the Code of Hammurabi, which, if you don't know, is literally the earliest legal document in recorded history. So as long as there has been a history of law, there has been exemptions from full punishment for people with mental illness. In common law, British law and American law, The Macnaghten rules were established in the 19th century in England, and the Macnaghten rules said the only thing that matters in determining whether someone should be held fully accountable for their action is whether their mental illness prevents them from knowing whether what they did is right or wrong, or from understanding what they're doing. If you are unable to control yourself but understand that it's wrong, you should still be held fully accountable by the law. That's the Macnaghten rule. It's fairly conservative, all right? In the 1950s, the United States adopted a much more lenient standard that they called the product test. And this said that you should have reduced punishment based on mental illness, or a different process of punishment based on mental illness, if your crime was a, quote, product of the mental illness, which is obviously very, very lenient compared to the Macnaghten rules. Laws and recommendations vary by state and generally try to find a compromise somewhere in between these two, and so most states fall somewhere in between these two. Less than 1% of defendants actually plead not guilty by reason of insanity, and only about a quarter of those pleas are successful, so despite what media sometimes makes it look like, it's actually very uncommon. Moreover, as I said, over the last 20 or so years, there's been this tendency toward looking at whether people should be held guilty and insane, and so it's a little bit of an increased risk around mentioning mental health issues in the setting of the courtroom, because you open up the possibility that you may be deemed guilty and insane, and you may be asked to serve required to serve not only your prison sentence, but then undergo assessment for whether you're still dangerous and potentially have an involuntary psychiatric hospitalization tacked onto it. So really interesting, really ethically questionable, but worth thinking about. So I appreciate you joining me. I hope this was educational. And I hope you have a good day.